less than 500, or if it's less than 1000, but there's a predictive decline to less than 500 in the next 48 hours. And based on neutropenia, the extent of neutropenia, we kind of grades the intensity ranging from mild to severe, life-threatening, and something called as profound neutropenia, which is less than 200. Now, neutropenia, is in our practice, hematology oncology practice, can be of various reasons, but in the context of today's discussion, we're going to restrict it to chemotherapy-induced neutropenia, which we know results 5 to 7 days, usually 5 to 7 days post chemotherapy due to destruction of neutrophil precursors in the bone marrow. And although neutropenia post chemotherapy would be predominantly determined by the chemotherapy the patient has received, but also to an extent by the age prior chemotherapy, radiotherapy, and also by the type of cancer which the patient has. And the consequences can be quite dramatic and disastrous, not only hospitalization and administration of antibiotics, but also the excessive healthcare expenditure in managing these febrile neutropenic episodes.
But I have to see the screen of them.
Chemotherapy dose delays or reductions, which in fact in turn can lead to reduced treatment effectiveness and sometimes compromise in the cure rates. We all know how febrile neutropenic episodes can reduce the quality of life and the mortality associated with it, especially the hematolymphoid and in transplant settings. So with that and this is just the graph to show you that how the duration as well as the extent of neutropenia can determine the prevalence of infection, serious infection in the patients. And if you've got a prolonged neutropenia more than 6 weeks, for example, neutropenia of less than 100, almost every patient, 100% patients will develop severe infections due to neutropenia. It's also dictated to an extent by the type of malignancy, and solid tumors a little less common than hematological malignancies. And of course, we can only find a site of infection in about 20 to 30% of patients. So with that prelude and with that context, I would try to discuss some of the points today, especially in context of neutropenia and outpatient management. Now, first question, Dr. Sarita, is your audiovisual working?
I think my visual is not working.
That's fine.
So
but we can hear you very well.
But I can't see your slide as well. So just ask the question.
I'll ask the question, but we can hear you very well. So my question to you, Dr. Sarita, is if you could, tell us, can you hear me? Are you able to hear me, Sarita?
Yeah.
So my first question would be that, what will the initial assessment a patient is coming to you with febrile neutropenia? What will the initial assessment and workup required? This stratification we'll do later on, but what will the initial assessment and workup required?
We assess the patient by, if a patient of, you mean to say patient is appearing with temperature, right?
Yes.
Yeah, so initial assessment immediately, if the temperature is more than 38.3 degree centigrade of one episode, or more than 38 degree for 2 episodes, like the continuing for 1 to 2 hours. So immediately we send the blood culture routine investigation. In that, CBC, CRP is the most important. Apart from that, KFT, LFT, and other parameters, along with 2 blood cultures. We know that our patient, most of them have already had central lines, so we should send 2 cultures, like from lumen if patient is having Hickman line. So we send from both the Hickman lines and the peripheral sample. And apart from that, urine sample is also sent for the culture. And these are the initial parameters we assess. And after that, if we start initially, hello, over to Dr. Sunil.
Yeah, so thank you, Dr. Sarita.
We can hear you, Dr.
As I think you kind of summarized it, good initial evaluation, which is a clinical history examination, systemic examination to find the focus of infection, and evaluation, especially blood count and biochemistry and blood cultures, which you mentioned, and of course other cultures based on any site which we can which are suspicious or not the examination. Radiology, of course, if required. Now, I think you made a very important point, and that's for all of us here. Blood cultures, both aerobic and anaerobic, is very, very important, and that is from peripheral blood cultures as well as from the central lines or any other long-term central venous access devices these patients have. And it's also important to take, if there are multiple lumens, a culture from each lumen. So that's one, I think, takeaway from here. And also another important takeaway is the adequate and appropriate amount of blood for culture, because we should never be, I would say, hesitant in taking enough blood for cultures, and whatever is recommended by the BACTEC bottle system, whatever you're using in the hospital, usually is 8 to 10 ml for adults and 3 to 5 ml for children, and that much of blood should be taken, and both in aerobic and anaerobic bottles. Fortunately, subpediatric bottles are both aerobic and anaerobic. We don't need additional bottles for that, but for adults, aerobic and aerobic bottles are different, and they need to be taken. Now, I think also important, I think what you mentioned was immediate assessment within 15 minutes at the triage, and antibiotics should go within 1 hour of presentation with fever in a patient of febrile neutropenia. Now, Dr. Amit, if you could just take this question, and that is, once you have seen this patient in your OPD, in your emergency, in your triage, and you have done the initial evaluation, you have taken the appropriate labs, you have given the first dose of antibiotic, what is the risk assessment you would now do, and which determines whether it's a high risk or low risk patient in context of febrile neutropenia, and what, based on the risk assessment, what would be a further strategy?
Yeah, sure. First of all, I want to introduce, I am from TMH Mumbai, not from Jamshedpur. And, secondly, to your question, the risk assessment we mainly do is based on the patient-related risk factors, the disease-related risk factor, and the treatment-related risk factors. In adult, basically, the patient-related risk factor, the advanced age of the patient, or the poor performance status, the nutrition status of the patient having low albumin, or the prior FN episode. If the patient have got an FN episode prior to first cycle of chemotherapy, then post in second or fourth cycle also it has increased chance of having the FN in that patient. And regarding the comorbidities, as the number of comorbidities increases in the patient, it is surely going to increase the number of the chances of further FN complications. Regarding the disease-related risk factors, basically the patient is about which malignancy it is, whether he is from a hematolymphoid malignancy or a solid malignancy, depending on and what is the stage of the disease and how is the response to the chemotherapy the patient is having, whether the disease is under remission or not. And further, the treatment-related regarding the chemotherapy which the patient is receiving, whether it's a high-dose chemotherapy like high dose of cisplatin, ifosfamide, cyclophosphamide, or etoposide, or it's a low dose therapy which he is receiving. So these are the general points which you take in consideration. But there are few guidelines regarding this. The most important of these are the clinical judgment rate, which we take in consideration regarding the organ failure the patient is having, regarding starting from whether there is any cardiac morbidity, any hypotension, shock, or any pneumonia, or any neurological complications the patient is having. And the secondary, there are few guidelines from MSCC scores which take in consideration the points more than 21 having low risk or less than 21 with high risk, or for the solid, and the Talcott score is also there, and with taking in consideration mainly the comorbidity and inpatient status of the patient. And the last is the CSNI for solid tumors, which we are using the CSNI score, which also takes in consideration this is a recent with performance status and mucositis and stress and hyperglycemia are the points which are taking in consideration. So all these factors are taking in consideration to decide whether it's a high risk or a low risk case.
So thank you, Amit. I think you covered it very well, and apologize for my ignorance about your current place you're working. I think you summarized it very well, like clinical judgment, and there are some scores which are available. I think MASC-CC you have mentioned, and you mentioned CISNA, which is the more of a clinical score, and also the Talcott rules. I think we'll discuss a little bit later on how this impacts in all the patient groups. But I think these are the scores which will help us to understand whether there's low risk or high risk patients. and the low risk ones are the ones which we can probably consider an outpatient management, and IV probably only for those who have documented infections and GI intolerance. But otherwise, high risk patients always will need inpatient management and would be managed as inpatient. So that was a good overview of how we risk stratify these patients where they go after they have been assessed and given the first dose of antibiotic. Now, Dr. Siddharth, if you could, take this, question. Once you have clinically assessed this patient and you have determined by what Dr. Amit said, based on their, based on the scores, based on the clinical judgment, and have decided for outpatient therapy because they're a low risk category. Is there anything additional from the psychosocial or logistic conditions which you need to probably assess before you discharge this patient home?
So first, I have to see from which region patient is coming from, because many of the patients are traveling from very far off region, and if they go home with the oral antibiotic and they deteriorate later on, then I will not be able to track them. Okay, so first thing is from which region that patient is coming from and what kind of medical facility he can receive at that place. Second thing, also I have to check what is the educational status and whether he is intelligent enough to understand the consequences of the drug that he has received and what kind of complication he can get into with febrile neutropenia over there. So that's what I have to check before sending someone, giving someone treatment on outpatient basis.
Yeah, so that's important. So I think what the point you're trying to make is that clinical assessment and judgment is important, but that may not be enough. I think they should be within approachable distance from the hospital if they have to come back to the hospital in case of worsening. And importantly, there should be a family caregiver who should be there with them 24 hours, who can keep a watch on them, and access to transport and telephone. And also, some people are notorious to not be following our advices. So if we know from the past history that they have been non-compliant, it may not be the right patient to send home. I think the very important point also you made was about their understanding, their educational understanding of the disease process and availability, readiness to follow advice. And I think most important also, one of the things I think I forgot to mention here is also our approachability. I think there should be a number, there should be a contact number where they can reach 24/7 if there is a need to call back. Now, Dr. Ruchira, a question to you. Now, we have assessed this patient as low risk. Then they come to a triage. You have seen them, you have taken bloods, should we give them IV antibiotics even if they are low risk? That's number one. And they have come to triage, or they have come to emergency department or OPD area. And how long would you like to observe them? So, and what antibiotic would you start if you're giving them, IV, if at all you're using that as the first step?
So the recommendations generally are that they should receive their first dose of antibiotics as an IV preparation, because they are in the hospital and being assessed at that moment. The first antibiotic should be administered within the first 1 hour of their presentation, which is the standard rule for all febrile neutropenic patients. But then observe them for at least for 4 hours to see whether they're deteriorating or not. And if you find that they're stable and they're not deteriorating, plus you've assessed their compliance issues and their logistic issues, and you think it's safe to be able to administer those drugs on an outpatient setting, only then should you be consider giving the medications on an outpatient setting. In most cases, we have generally followed giving what we follow as our first line drugs, which is piperacillin, tazobactam, or ceftriaxone as our first line antibiotics. But every hospital should have their own antibiotic policy, is what I feel. And based on that, they should administer their first antibiotic on that basis.
So thank you very much, Ruchira. Yes, that's correct. So I think first antibiotic should always be IV, and that IV antibiotic should be based on antibiogram. There should be unit policy of what first line antibiotics to be given, and that should be revised every 6 months preferably, but at least once in a year. There are some situations, where you suspect catheter-related infection. There is a hemodynamic instability. Of course, they will not come in low risk anyways. If there's a prior antibiotic resistance documented, we have got, prior multi-drug resistant infections with all of these here. So these are the ones I think they will probably need to come in to the hospital. Now, Dr. Shobha, once you've seen them, what antibiotics would you give them? I think IV, Dr. Richard I just mentioned, which will be probably our hospital guideline. But what antibiotics for outpatient use, and how strong is the data there, and what are the caveats in what we use as oral antibiotics on outpatient basis?
Oral antibiotics, the data, IDSA guidelines and other guidelines have told amoxicillin clavulinate with ciprofloxacin, or ciprofloxacin monotherapy is also being told. There's also data on there's also data on fluoroquinolones, provided the child was not on fluoroquinolone prophylaxis. Cefepime is also being used, and these are the recommended data orally for the children on the first day after the first IV antibiotic.
So anything different in adults, Dr. Shobha has kind of mentioned for children. Amit, anything you use differently for adults, and any other thoughts on oral antibiotic choice?
We generally don't use fluoroquinolones upfront because it is being used in ATT and we don't want to use this drug. So really go for suppor upfront for all the patients we are planning oral.
So what's that? Sorry, what do you use?
You use cefuroxime-azathioprine.
Okay.
For the patients mostly.
Okay. As monotherapy, cefroxime?
Yeah, that's a monotherapy only we are using.
Dr. Siddharth, anything else you want to mention here? Because I know this data is quite soft, so that's why I'm taking your opinions here. What would be the choices you guys make in your day-to-day practice?
I generally go ahead with amoxicillin and clavulinate combination. And levofloxacin and ciprofloxacin, most of these patients are resistant to these drugs, and the resistance develop to fluoroquinolones very easily. So that's why these drugs are not that much used in our setting most of the time. So in whatever resistance pattern that we have seen with fluoroquinolones, mostly the patients are resistant to these drugs. So it is not being used in our setup. One of the study that I was part of a retrospective study in ICU patients, nearly all the patients were resistant to ciprofloxacin and levofloxacin. That's all our experience while we were in TMH. And better not to use these drugs because patients develop resistance very easily to these drugs.
Okay. So I think varied, what I could gather is that it's a varied experience here. So, there's also some of the units also I know that use third generation oral cephalosporin like, cefixime as also monotherapy, and we use that quite commonly in children as a monotherapy, or we use ciprofloxacin and amoxicillin clavulinate. Probably in children, ciprofloxacin, resistance is probably not that common, so that may be one of the reasons, the outcome is a little better in children. So anyway, so if now Dr. Amit, if the fever, you have sent the the patient home, and fever doesn't settle, what to do? I mean, do they necessarily come back to the hospital, or what is the advice for them?
Yeah, we generally see the patient, ask them to at least visit the hospital once daily once or every alternate day. And if the fever doesn't settle, but the patient is there is no other complication, we can continue with the same. But after 3 days of that, we have to reevaluate the patient with a repeat history examination and a repeat blood culture sets, and to find out any other site of infection if the patient is having, and then to modify the treatment accordingly.
So it's important to keep a watch on them. They may not be coming to the hospital probably every day, but yes, it's important to keep a watch on them and ask them to report back. I think if this is what I could gather, and if there is, as you said, after 3 days the fever is still continuing, fever has recurred, especially after initially responding. There are new signs. He or she is not tolerating antibiotics orally. And based on microbiology, if you've got a culture which is positive and is only sensitive to parental antibiotic, then of course you'll probably admit them. Now, how long will you give the antibiotics, Dr. Amit, once you have chosen oral antibiotic therapy?
If patient is low risk, in that case, at least 48 hours till after the subsidence of fever, and when the ANC count is more than 500. These 2 points have to be taken in consideration to stop the antibiotics.
Sure. Now I'll just take, next, we have Kashish, 4 more minutes, 4-5 more minutes.
So we have 8.5 minutes.
Okay, good. See, I just take some.
Dr. Sunil, as an organizer, can I request you to please 2-3 minutes? That will help us.
Yes, we'll do that. We'll do that.
Maybe by 5 minutes you can. So sorry.
No worries. So, special circumstances, one which is important one, I think that was probably the logic also of Dr. Adip to give this. Any difference between pediatrics and adults, in context of outpatient management? Is Dr. Sarita there? Because she's got a reasonable experience in both settings. Dr. Sarita, can you hear us?
Yeah, I can hear.
Yeah, so dealing with febrile neutropenia on an outpatient basis, differences between pediatric and adult patients. What's your thoughts on that? What differences are there, and what do you see in common practice? What are the differences in the two populations?
Usually, pediatric patients we don't treat as an outpatient. We have to admit them because we don't want to take a chance, because they deteriorate very fast. In adult case, of course, they will be able to manage and they can speak about the problem. So problem is the main thing, the clinically. So we don't prefer to treat the pediatric as an outpatient, but yes.
Okay. Any other thoughts from others? Ruchira, you want to, or Shobha want to make a point here before I ask my adult colleagues to comment?
As Dr. Sarita said, pediatric patients do have a tendency to deteriorate very quickly. If they do so, there should be a provision to keep a very close eye on them. And I would only advocate treatment as an outpatient if you have very good proactive caregivers looking after them. So, plus the pediatric doses are very different. So I can't really expect any general practitioner to be able to look after them very quickly. There should be in very close proximity to the hospital to be able to come in quickly if there is a clinical deterioration. They won't give us time if they start deteriorating.
Another thing I would like to notice in what phase of, for example, if this is a newly diagnosed leukemia, the parents themselves are still in they are still educating themselves. They don't know how to detect problems. But if the same child comes as febrile neutropenia in the maintenance phase, they are more educated. So I think it depends on the phase also. I'm more confident in treating a child on outpatient basis if the child is in a later phase of the treatment and comes as a febrile neutropenia than in the early phase of treatment. Because in the early phase of treatment, even though the child looks well, I'm not confident about the parents' ability to detect subtle signs of deterioration, like child sleeping a lot. Yeah, that's the thing. So.
Dr. Siddharth?
So, like as Madam has said, in pediatric patient, the most of the regimens are they are very toxic. In solid tumors in adults, it is generally the neutropenia is not that long. It is easy for us in that perspective also. And again, pediatric patient mostly they are hematological malignancies. Or other malignancies, the chemotherapy itself, the chances of neutropenia prolongation is very long.
Yeah, so I think that's important points you highlighted, all of you. Pediatric patients, more hematolymphoid, more myelosuppressive chemotherapies, difficult to assess by the caretaker clinically because they may not be able to report the symptoms. Number 3, they deteriorate very fast. And I think one of the important things also I feel that we lack objective tools in pediatrics. These scores which I just mentioned earlier, they are all adult oriented, COPDs and hyperglycemias and so comorbidities. These are all adult oriented. I think we still lack a very good objective tool in pediatrics to assess them objectively. So the next question to you, Siddharth, is that neutropenia elderly, although we don't deal with adults and elderly people, but I think is that a separate entity, and do you deal with them differently in elderly people?
I mostly don't treat them on outpatient basis. Mostly it is an inpatient treatment for them if they present with fever. Elderly means more than 70 years of age, not just 65, but 70 years of age, someone who is PS2 and above. So those patients, it is better to treat them on this basis. But many a time, their relative doesn't bring the patient so frequently, and most of the time the connect is through telephone only. So I have to tell them sometimes oral antibiotic on telephone basis, although not very standard, but there is no other option for me.
Correct. And And with radiotherapy, Ruchira, anything specific neutropenia and radiotherapy, again a special circumstance also sometimes we encounter. The patients are getting concurrent radiotherapies. You have to unmute yourself, Ruchira.
So with radiotherapy, we really need to assess what is the level of neutropenia that they're reaching with the radiotherapy. If it's severe neutropenia, then the radiotherapy will need to be stopped, and they will need to be put on antibiotics. Most of the time, we have been giving IV antibiotics to these children because in those cases, we've noticed that the neutropenia may sometimes be very prolonged as well, and we sometimes used GCSF with these patients as well. It becomes an independent risk factor for all our neutropenics if they are getting it. Also, our cutoffs are a little bit higher with the radiotherapy patients who are getting radiotherapy.
So before we conclude now the session today, we have discussed how to identify these patients, how to manage them on outpatient. Prevention strategy, Shobha, how do you prevent, at least to an extent, these febrile neutropenic episodes?
So prevention is, we can consider it as in two aspects. One is to reduce the duration of neutropenia, in which case we have the growth factors, and the second thing is the reduce the chances of getting infected. So when it comes to growth factors, not all cancers require growth factors, but in those chemotherapy regimens which have a higher risk of going into prolonged neutropenia, there we need growth factor support. Although the recommendation is to start from third day, it's easier to educate the parent to start the very next day of finishing the chemotherapy and continuing it for 5 days or week or so, depending on the previous experience, how long the child required to bring up the count. And the second aspect of prevention is the prevention of infection itself. So infection prevention is basically hygiene. We would like to educate the parents about hand hygiene and daily baths, and also the food aspect, so that they don't acquire infection from the external sources. As far as the infection from the bacteria within the body, as much as possible, we try to prevent breaches in the skin and the mucosa by using mouthwashes, sits bath regularly, so that if they have any constipation, then there is no anal tear, perianal tear. So these are some of the methods to prevent infection. Although it's most of the patients, parents are aware of these methods. Despite that, they do get fever, but these are some of the methods that we can use to prevent fever and reduce the duration of neutropenia.
Thank you, Shobha. That was quite comprehensive. Anything, Dr. Amit, you want to add from any adult perspective to prevention, GCSF, preventive strategies, anything else?
No, it's the same in the adult. Also, we follow the same things. Oral care and
yeah, Shobha, sorry.
Also, we would, if a child is receiving a particular regimen, and we have found, especially in solid tumors, we have found that they have repeated neutropenic episodes with fever, we could consider reducing the dose in the next regimen. That is one other way.
Although very controversial, because that may also affect the outcomes.
Right.
Correct. So I think these are my last couple of slides. So I think we have discussed today, initial assessment of the patient within 15 days of coming. We should know what chemotherapy they have received. We should know how what is any focus is there. We should conduct a good examination and a history, biological diagnosis as soon as they arrive. And within the first hour, they should receive empirical antibiotic. Once that has been done, we re-stratify those patients based on the scores which we just discussed, and also our clinical judgment, and we discuss them as high risk and low risk. High risk have to be admitted straight away as inpatient. Those who are low risk, based on the clinical scores, if they are falling into lower intermediate risk score, then we will assess them for logistic and psychosocial supports at home, and we can discharge them as outpatient after observing them for at least 4 hours in the inpatient facility. And we will start them as oral empirical therapy, which has been decided by the unit and the institution policy as institution policy. So that is how we will approach these patients for outpatient management. So thank you very much for your attention, and thank you the great panelists I had, and it was really wonderful interacting with you. Over to you, sir, Dr. Sharath, and if there are any questions, we can take them. Thank you very much.
Thank you, Sunil, for that nice, wonderful, and very lively discussion of febrile neutropenia. Again, with a lot of take-home points, I think, for members of the collegium and everybody who's listening.